Good morning, everyone. I'm Dr. Sara Mustafa from DentistChannel.Online. Welcome to our today's webinar about dental implants, lecture and planning. If you have any question about this topic, please feel free to ask it in the Q&A box, and we will answer each and every question at the end of the session. I will start by introducing our speaker, Dr. Syed Zafar Abbas. Dr. Abbas from Pakistan, he cleared his BDS in 2011. He has a postgraduate degree in oral and maxillofacial surgery. He is also certified as an implantologist and holds a diploma in facial aesthetics. Currently, he has started an organization, namely the Royal Academy of Facial Aesthetics. He is soon conducting a course on facial aesthetics and the basics of implant hands-on. Welcome, Dr. Abbas. It's our pleasure to have you with us.
Thank you very much. So we can start it now?
Yes, please.
Okay, I'm sharing my screen. As Dr. Sara has already introduced me, so we will start our topic. First of all, I will like to cover some basic thing before placement of implant. First of all, we should know the basic thing before placement of implant. Before placement of implant, obviously thing we need to extract the tooth. We know the planning of soft tissue with preservation, whether it is hard tissue or soft tissue, because it's very important in long-term function and aesthetic. And most important, what type of flap you are giving. Usually people are more interested in implant, how we can place implant, what will be the diameter, what will be the angle, what will be the length. But usually they forget about the basic principles. If you fulfill the basic principle, then your implant will be more successful. So today lecture will be more consider about the basics thing. Most importantly, atraumatic extraction. If a patient come to you mostly in anterior lesion, mostly very important in anterior lesion, you should go for atraumatic extraction. How will you do atraumatic extraction if you are planning for an implant? If you fracture the bone, it's very difficult that implant will be successful. So I will mostly covering this topic. Okay, this three topic in today's lecture. How will you can do atraumatic extraction? As I already mentioned. Wait a minute. As I already mentioned, when we are doing extraction of a tooth, we know that there are 5 principles: buccal, lingual, rotational, traction, apical forces. Mostly in anterior tooth, we are using buccal and lingual movement like this, buccal and lingual and buccal and lingual. as we all know, the buccal walls is very thin. It's usually mostly it fracture when we are doing extraction in anterior tooth. So we have to preserve the buccal bone for placement of implant. Because if we fracture the tooth, there will be bony defect, distribution of blood supply will be compromised. If blood supply is compromised, then healing will compromise. There will be inflammation, even infection. Sometimes if there can be also soft tissue damage. Studies has also shown if we do extraction in anterior region, there will be horizontal bone loss almost 3.8 mm, and in vertical reduction there will be 1.24 mm during 6-month interval. Like this is the socket. Horizontal bone loss will be like this, and vertical bone loss will be like this. If you have noticed, if you have done extraction, always after 2-3 months you will see there is a knife edge ridge. When patient come to you for any placement of implant or denture, you will see there is a knife edge like this. Because first of all, horizontal bone loss occurred, then after horizontal bone loss occurred, then vertical bone resorption start. Okay, after extraction, buccal plate resolve much faster as compared to the lingual plate. The thing which I was talking about, mostly the buccal fracture if we do the buccal movement. So how can we preserve? You will say why we are using the forceps. We can use elevator in the mesial or distal. Yeah, we can use it, but it will traumatize the soft tissue and hard tissue. You have to do something which give less trauma, and you can place implant immediate loading. Okay. Mostly when we do extraction, there is a bony defect like this, and after we place implant, we see there is a apex opening. Mostly in anterior cases, we mostly see this kind of cases, especially in anterior with where we have to preserve the smile line. How we can save it? There are 4 principles for atraumatic extraction. First of all, atraumatic extraction can be done. You can use a blade. If there is a tooth, use a blade of 15 surgical blade, 15 number surgical blade, and run in circumferential way like this. It will help the connective tissue fiber. We have almost 13 connective tissue fibers which are attached to the tooth, and 6 are Sharpie fibers. We already know. They are inserted into the cementum of the tooth and alveolar process. So first of all, we will run a blade around the tooth. So it will loosen all the connective tissue. Then second, minimum soft tissue reflection. We all know that the blood supply and the periodicity will depend on the soft tissue. So minimum soft tissue reflection, if there is not surgical indication, if you fracture the root or something like that, minimum soft tissue reflection like this. Minimum, no vertical incision. Okay, no vertical incision, because it will compromise the blood supply and healing will be delayed. The cortical bone receive almost 90% of the arterial blood supply and 100% of the venous distance through the periosteum. Like periosteum the bone receive the 90%, 80% of the arterial blood. That's why blood supply is very important. If you reflect and give vertical incision, but blood supply will be compromised. Okay, this is a second important point. Third point, section. If there is a multi-root tooth, section it. If there is a molar, you divide it from buccal to lingual like this. This is the buccal, this is the lingual. Use the handpiece and divide it and section it in two. But in the molar have three roots. You already know. On upper, this look like this. This is the palatal, and this is the buccal. We already know there is two roots. So then we will divide like this. First, we will insert from mesial to distal handpiece. Divide like this. Then we divide the two roots like this. Palatal will be removed separately, and this root will be removed separately, like this in this picture. You can see. First we have divided the palatal root. Then we have sectioned these two roots. Then we will remove this root separately. This is very easy treatment. We will, if you are not placing an implant and you will use this in your normal practice, it will also help you in easy extraction. As I am a surgeon, it usually save my time if I divide the tooth separately and remove the root separately. It is very easy treatment. It also saves the soft tissue, save the bone, less traumatized. And last point, most importantly, if there is a tooth which have the contact point like this tooth has a contact point, reduce the contact point. Because if you are removing the tooth, it can hinder the adjacent tooth. It can also mobile the tooth. Even if there is a contact point and you are placing the elevator or forceps, the forces will not be equally given to this tooth because there is a contact point. So you have to remove the pathway of any obstruction that causing the tooth side to be removed. Okay, we remove the mesial and distal side of the tooth. So all the pressure, all the forces only engage to the tooth, not on the adjacent tooth. This is the fourth principle. If you're planning for atraumatic extraction, especially in the anterior region, this is very helpful. Okay, now there is an instrument called periotome instruments. Obviously, everything you have already listened to about this instrument. This is the periotome instrument, which is specially designed for extraction of the anterior tooth with less trauma. I will show you the picture of, first of all, like this instrument is like this. If you are planning for implant, you don't use normal elevators, you use this kind of elevator. First of all, this is the BDR. The periotome blades are inserted in long axis in this lesion like this. Blades are inserted in this. But on mesial or distal side, not on the facial plate. As we already know, facial plate is very thin, it can fracture. So we will lightly insert in the mesial, and then with mallet we will taper it like this. Taper it and leave it for 10 to 20 seconds. Then we will taper it again. Then we leave it for 10 to 20 seconds. As the material is flexible, it will make its own pathway and will insert and will go in the pathway. Like this. This is the periotome. You have inserted, and we already know that the tooth is like this, convex like this. We will insert the instrument, taper it, leave it for 10 to 20 seconds, then taper it, leave it for 10 to 20 seconds, then taper it then leave it for 10 to 20 seconds. After you think the instrument is inserted, then we will move a jiggling movement, like the little bit jiggling movement. Then we will convert into the elevator. Then we will elevate the little bit and we will little bit rotate it. As the instrument will go in, then it will mobile the tooth, or the BDR will be luxate out. But if the tooth is mobile, then we will, if you think the tooth is mobile and grade 2 mobility is there, then we will use a conventional forceps or normal forceps we use for the extraction. only if the tooth is mobile. This is one of my case. This especially this. I was planning for an implant and the root fracture. At that time, I don't have periostal, and almost one third of the root or two-thirds of the root was there. Then I use a file, normal file which used in endo. I engage it in the. I first of all clean it, clean the socket, look for the canal. I engage in it, and I engage tightly in it. Then I pull out it. Then the root was extracted out from the socket. If you don't have the instrument, you can also try this procedure in normal extraction. Almost 100% it works if you know how to engage the file properly and tight the properly. Mostly we use 40, 50, 60 file in it. Second important thing, we have learned the atraumatic extraction. What will be the second most important thing? When to graft or when to not to graft. We already know there are 4 wall of the socket: mesial, distal, buccal, lingual, and apical. Depend on the how much is the defect, which wall is missing, wall is thin, depend on, then we will plan on the graft. If you see the socket like this and have all 5 wall preserved, buccal, lingual, mesial, distal, and apex, all you think all 4 wall are intact, then you will have to do, and you think, you see there is almost 1.5 mm thick bone. There is nothing to do. This is the ideal socket. This is the ideal socket. You can place implant immediately and no bone grafting or membrane is required in this. One more thing I would like to share with you. Mostly when I do the anterior extraction, especially in the anterior region, and I think, and I look, the socket is very much clean, all bone are intact, then I use my periosteal elevator, and I insert in the socket like this, and place my finger over here on the buccal side inside the lip, and I run the periosteal against this is the bone, buccal bone, and I run the periosteal against my wall. If there is a bony defect, my finger will feel it. Mostly when we do the extraction, all walls are intact, but in the apex lesion, sometimes there is a bony defect due to the infection. So this is my recommendation to everyone: insert the periosteal and run it on the buccal wall and place a finger on it. If there is a bony defect, you will always feel it in your finger. This is my special instruction to everyone. Use this, it always help it. Okay, we will on the 5 wall extraction, 5 wall socket. All wall are intact, no need, and the is greater than buccal wall, and all wall are greater than 1.5 mm. No need of. This is the ideal situation for placement of implant. If there are 5 wall, but any wall is less than 1 mm, then you need bone grafting. If there is a 4 wall, 1 wall is missing. If there is 1 wall missing like in this video, then bone grafting is necessary. Only bone grafting. Obviously, thing is there is 2, 3 or wall missing. Bone grafting with membrane is needed, but when you will insert, when you are planning for membrane, first of all, look at this chart. This I was telling about you this chart. If there is 5 wall and all walls are intact and greater than optional, you can place bone graft, not necessary, but you can place implant immediate loading. If there is thin, recommended. If there is 4-wall defect, highly recommended. If there is 2, 3 or 1 wall, it is very, very, very high recommended. You have to place something in it. If you do not place something in it, patient will come after 2 to 3 months. You will see a very thin bony wall. This is an example. You have extracted the tooth. You have placed the bone socket. Patient come after 6 months. You will see this kind of bone. You have extracted the tooth. Socket will heal. Bone resorption will occur. When patient come to you, there will be a knife edge. Then you will have to do something opposite to it. What kind of bone grafting material you are planning to do? This is the most important thing. What kind of bone? We already know there are 2 membrane, resorbable membrane and non-resorbable membrane, and there are allograft material and exograft material, bone graft material. The allograft material, they can be demineralized or mineralized. In demineralized or mineralized are extract out. In frozen dried bone, all mineralized are intact. In implant, we usually, after implant placement, we usually sometimes we need two things: bone grafting material and barrier, which we call membrane. This is a type of bone we seen in our practice. Okay. Because of remaining calcium and phosphate salt, FDBA tend to resolve much faster. Therefore, much slower. FDBA resolve much slower. If there is a bony material which is resolving very much slow, then this means they can maintain a space much longer time. What is the benefit of this? If you have placed bone in the socket or in the implant, it will maintain its space through the long term. Why it is important if resolving delay? Because we already know soft tissue healing and soft tissue occur much faster as compared to hard tissue. Soft tissue invasion will occur faster if there is a bony defect, if there is bone resolve faster. That's why mostly surgeons recommend FDB, a frozen bone, which contain mineralized. Mostly in sentinel size of canine, we need 0.5 to 1 cc. In lateral, we need almost 0.5 cc. In bicuspid, we almost 0.5 to 1 cc. In molar obviously thing we already know is a big socket. We need 1 to 2 cc bone. Okay, now we are talking about the barrier. Which kind of barrier we need in which kind of socket, in which type of defect. Obviously thing we have discussed about the bony wall defect. But when we will place the membrane is also important. Are we planning to place a membrane in it or not? Why if you have packed the bone on the socket, in the socket, and you place soft tissue, why you need a membrane? Why? Because if I will place a membrane and soft tissue will touch the membrane, then there will be a fibroblastic activity, and the whole bone will convert into soft tissue. That's why we need something which differentiate the bone from the membrane, which separate barrier, something like this, which separate the bone and membrane from it. Okay. We have 2 types of membrane. We already know resorbable and non-resorbable. Okay. If there is a 5-volt socket and all bone are intact, but as we have already discussed, if there is less than 5 mm thick bone, thin bone, then we will only place bone grafting material in it and cover it with collagen sponge like this. This is the collagen sponge. We will only cover it and then we will suture it. Which kind of suture we will do? Crisscross suture technique. First, we will go from the mesial side. Then we will insert in the distal side. Then we'll again come into the mesial and distal. Then we will suture it like this. We are going from the mesial, distal, mesial, then we will suture it like this. Hopefully this picture is clear to everyone. Then we are going to the mesial side, then the distal side, then we were adding the knot, 2 clockwise and 1 anti-clockwise. You already know the principle. This will hold the collagen sponge in the socket. If there are four wall socket defect, we already know if we will place the bone in it and close it with only close it with something, we close the suture, we close it like this, the bony defect will appear like this, because the bone, it will because it's a powder. Bone is like a powder. It can manipulate if you move, if there is lip movement, there is a muscle movement, the bone will be immobilized. We need something to protect it, something like this to give the tenting effect, something which can give the conversion like this. We can use a membrane. We will insert a membrane and we will insert the membrane in the buccal. So if there is a buccal defect, we will insert it in it and convert it in it like this. You can see it in the picture. First of all, we have placed the membrane in the buccal, like the tunneling. We do the tunneling like this. We have placed the membrane in the buccal, and after placement, we will have converted into the palatal wall. First of all, we will insert the membrane, then we will do the bone grafting, then we will rotate it and insert in the socket in this palatal tissue, inside the palatal tissue. Then we will suture it. But in this type of membrane, we need something which is long lasting, which cannot easily manipulate, or something which can hold tightly. Maybe non-resorbable membrane or resorbable membrane, but long-lasting membrane. And this is the most important. If there is 3, 2, or 1 wall in the socket, what we will do? First of all, we need something. We are using alloplastic material, but with alloplastic, we need something autogenous bone graft, because it's a huge bony defect. We cannot predict what will be the outcome. Mostly in this socket, we cannot predict after placement of bone what will be the outcome. That's why we cannot take any chance. We will use the allograft material and mix with the autogenous bone graft. Where we can use the autogenous bone graft? From the ramus, from the symphysis, from the maxillary tuberosity. We mix it with the hollow bone graft. Okay. Then we can also mix with PRP, PRF, spongy bone graft. We can also mix this kind of thing with it. Because they have growth factors in it, they will induce the healing process, and there will be a good healing, and outcome will be huge. Obviously, thing there is, if you can see in this picture, if you are planning for implant placement or in future, and there is a bony defect in buccal and lingual and all around the tooth, what will you do? Because bone is there. If you close it like this, this will be the bony defect like this. Now we will be needing something that can hold the tooth, hold the bone, hold the soft tissue to this position. This is called tunneling technique. Tunneling technique. Then we will place something in it, screw-like. we have placed a screw. We have placed the bone in it. It will hold the bone, it will hold the soft tissue, then we will suture it. Or we can also use a titanium plate like this. 2 screw over here to hold the titanium, 2 screw over here to hold the titanium like this. Because you need something which can give the shape, anatomy. After 6 months, when you are opening the tissue, you opening for implant placement, you can see a fine and a good bone in it. Soft tissue, if you are placing an membrane, it take almost 3 weeks to heal. If you are placing a hard tissue healing, it almost take 4 months. If there is a large bony defect, it almost takes 6 months. Obviously thing, if you are placing a bone, you will, and there is a small circle, you will call the patient after 4 months. But if there is a huge bony defect and you have placed an implant in large chunk, you will call the patient after 6 months. Most important thing you can see in this picture, mostly when dentists are placing a bone, they forget to place till the end of the tooth. You can see their socket, the apex are empty. So mostly you first insert in the socket, then cover the whole thing. And after the bone grafting, you also take x-rays. You can predict, you can also clearly see it. Was the mistake in this picture? Over bone have been inserted in this. As you already know, no membrane. If there is no membrane, there will be immobility. If there is immobility of the bone, it will not occur in the bone, and obviously thing that will not heal, and it will be disturbed in the healing process, and patient will be discomfort. So we will always make the anatomy properly. Same mistake, apex not filled. This is one of my case. I will like to show you. I have done bony allograft bone graft in this patient with unresorbable membrane and tightening suture. But after I called the patient after 6 months, when I open the flap, there's also a little bit of bony bone was formed, but same bony defect. As you can see, same bony defect. Now patient has come for implant placement. Now what I can give the best treatment to the patient. First of all, I start the drilling. I drill now there is almost less than 1 mm bone. Less than 1 mm bone around the implant is a great no. But I take the risk. I place the implant. Now you can see there is implant is little bit exposed from the buccal side. I take the titanium mesh. You can see the titanium mesh. I take the titanium mesh. I drill it with 2 screws to hold it. I place the bony graft and I cover it with the soft tissue. But amazingly, when the patient come to me, you can see a thick, almost 5 mm to 4 mm bone on the buccal side. That's why titanium, because titanium may hold the what shape you have given to the titanium bone will form like this. I have given this shape. You can see there is a good, healthy, almost thick, very thick bone on the buccal socket. Patient was very happy. The bony defect was covered. As I have done 2 times bone grafting in this patient. First time with the resorbable membrane, which did not give me a good result. Then I go for the titanium mesh, which gave me an amazing result. But everything comes with something. If you are placing a titanium, there will be, you need a second surgical intervention. I have to give the flap, the same flap. Patient will also traumatize again. And it can also expose during the healing process. You can, if you were given a titanium, and you can see the titanium occurring from the soft tissue. Something come great advantage comes with also great disadvantage. Titanium had this kind of disadvantage. You need second surgery. But in a absorbable membrane, you all don't never need a second surgery. But if there is bone formation. Okay, what kind of flap we can give during the implant phase? And punch flap, you punch the soft tissue, but it is what is the disadvantage of the punch flap? You cannot do the bone grafting in it. You only punch it and start the drilling. Half punch, you give the incision buccal to the mesial to the distal and half punch. In this, you can do the bone grafting. Many crystal incision, mostly we use this kind of incision in our practice, mid crystal incision. Sometimes we use conventional incision on one side, on both sides. Mid palatine incision, mid crystal incision is in on the mid. If you going little bit palatally, is the mid palatal incision. One papilla is preserved, then it's mid papilla preserved. As you already know, we try to not give any vertical incision, but sometimes if it needed, and only one vertical incision is recommended, but in some cases, not on all cases. Annular incision, this is the most mid crystal incision and annular incision, the most common practice, and we mostly do this kind of practice. We run the blade around the tooth and insert and incises. Then we will raise the envelope flap like this on the both side. But we try to reflect as less as we can, because after the flap, you have reflect the flap. Then from how much the flap have you raised, on all sides there will be a bone resorption. Almost article and research have given the guideline there is almost 0.5 to 1 mm bone resorption after reflection of flap. This is full thickness. If you are placing, mostly we use this kind of flap in full mouth rehab, or there is almost 2 to 3 implant placement in we are planning. Already we have given you this is periotome. Okay, I have covered my topic of flaps planning, atraumatic extraction, and how will you extract the tooth, what is the protocol for bony defect, and when will you place the bone or when you place the membrane. Now I will giving you a little bit concept of the implant and what kind of diameter, angulation, position we will do. If there is, the guidelines said if there is implant less than 3 mm, it goes in the category of mini implant. Not the ortho one mini implant, the dental implant, which like this. This is not the ortho implant. Mostly people confuse it with the ortho implant. Mini implant mean less than 3 mm. Mostly PDF approved this kind of sizes, 3.5. Obviously thing we have seen the implant, or there are 3.5, 3.8, 4.2, 5, 6, and there is a different diameter, length. Mostly you can see 6 mm only in 5 mm or more than in 5 mm. In there are different type of companies. Every company has their own sizes. Like if I am talking about 3.5, they must have 3.4. I have seen 3.2. I have seen 2.8. I have seen 4 mm implant. But this is the obvious thing. We already know what the size and what is the diameter of the implant. We already know there is the threads. This is the platform switching, the micro threads. Every system had its own design and own. Mostly now the implant has become tapered. The old implant was cylindrical like this. Now the new implant has become tapered. But some system also have both things, taper and cylindrical. If you're talking about Strowman, the Strowman have every kind of implant. The whole variety of implant have a Strowman have. There is the top industries we already heard about Strowman. Usually, if you talk about Strowman, you talk about Noble Biocare, you talk about Biohorizon, you call about Zimmer. They are the top 5 implant I have come across. They have also very much expensive implant. They almost cost very much. If mostly I usually use this kind of implant when patient is paying 4 times as compared to the normal implant I use in my practice, because this implant is very much expensive. But this implant is internationally recommend even if you are placing in any country, and if your patient go to any country like America, he can find this part anywhere in the world. Especially Strowman and Noble Biocare. They are the and Biohorizon. They can find their parts in anywhere of the earth. Okay, I will like to cover it fastly. As we already know, what is the contraindication in which patient cannot place an implant if he is a chain smoker, if he has uncontrolled diabetic, if he is hypertensive, he is going through any chemo, radiation. Is most importantly, if he has an unrealistic expectation. Patient come in our OPDs with unrealistic expectation, never treat that patient. It will cause chaos in further. Okay, we already know there are 4 types of bone: D1, D2, D3, D4. D1 in the lower anterior mandible, D2 in lower posterior mandible, D3 in upper anterior maxilla, and D4 in upper posterior maxilla. Okay. Before placement of implant, you must you mostly when patient come to you and demand replacement, and if we know about the implant, sometimes patients say I want an implant, and the dentist think, oh, now there is an time to earn money. Without examination, without assessing, they place an implant, and after this picture come. Will you place implant in this type of case? I have seen my colleagues placing implant without assisting the crown ratio, crown height space. They place implant, and after some time, there is no space. Okay, this is an important thing to before placement of implant. Now, I will recommend everyone before placement of implant, planning of implant, plan for the crown. It will save you. It will save your practice. It will also save you in future. Like this type of case, will you place implant in lower arch? If you place an implant, there is no space for crown. You need something you need to separate up the tooth, or you need to root canal or crown the tooth, or you need to extract the tooth to make some space. Minimum 5 mm space required for the crown. you need almost at least 5 mm space for the crown, and from the bone to the occlusal plane, 8 mm space. After placement of implant, if you have 5 mm of space, then place an implant. Otherwise, do something to the adjacent tooth, because after placement of implant, you don't have space, the implant will be of no need. Okay. Anatomical marking and what size, what diameter will you place? If patient come to you with an OPG, mostly in our country, patient usually don't go for CBCT as it is expensive. So mostly they come with OPG. Mostly in our country, patients are almost 50 to 60% patient are assessing on their OPGs. So you know all the reading, all the assessment we do on the OPG. If patient come to you with this case, you mark with the scale. There is almost I'm assessing almost there is 13 mm. Okay, all OPGs has almost 20% magnification error. This means you have to subtract 20% from it. Almost we will have, how much we will have? 8. I'm assessing almost we will have 10 mm like this. After canal, if you have seen the canal running, this is, you have to give some safe margin. Guideline recommend from inferior canal 2 mm. Okay, you have to give safe margin -10 from 2. Almost 8 mm implant you will plan on it. I hope you understand what I am saying. One more important thing, if patient come to you, I think I have a picture of it. Unfortunately, I don't have. Okay. I would like to share some OPG to you. I was sharing one of my OPG. Okay, this is the OPG. If patient come to you, placement of implant in this, what will we plan? You can see the canal running over here and foramen is over here. Okay, one more thing, if you are planning implant over here, what will be the recommendation? I will tell you the recommendation. Mostly this is the foramen and canal is running like this. Studies have shown canal run like this, and after the turn, it goes inside. If you see the foramen, you have to give 5 mm safe margin till there, because the canal will be running from like this. So 5 mm safe margin. You cannot go beyond this margin. Mean what? If foramen is there, does not matter. You have to give measly 4 mm safe margin. Okay. Have I already told you, you need 2 mm safe margin, 2 mm safe margin, 2 mm safe margin. Okay. Now we will, how much is this? I am assuming this is almost 20 mm. Okay, I'm assuming this from bone level to canal, this is 20 mm. We will subtracting 20% from it, almost 16 mm is safe. Then we will minus the 2 mm of the safe margin, 14 mm is safe. You cannot see it. You cannot see what I am drawing. Okay, I'm trying to copy it from the PowerPoint. Only image visible. Okay, okay. I tried on now visible. Now the drawing is visible. Okay. What I have drawing on it, you can now see it. Yes. Okay. Okay. So you want me to repeat it again? Maybe you have not seen it. Okay. I undo everything, then I will show you. Okay, this kind of patient come to you OPD. I hope you are now seeing what I am writing. Okay. If this kind of patient come to you in OPD, you can see the canal running over here. You can see the foramen. Okay. As I already told you, when there is a foramen, but the nerve usually run 5 mm anterior to it. It goes and turn and come back to it. So guidelines say when you see the foramen, you have to give 5 mm safe margin anterior to it. This means if there is a foramen, but it will be running 5 mm and 5 mm anterior. So you will also give 5 mm safe margin from it. We already know from canal we have to give how much? 2 mm safe margin. As when you see the OPG, you already know you have to minus abstract 20% magnification error from it. If I am this is bone level, this is the canal, and I am assessing from my scale, this is 20 mm. I'm assessing this is 20 mm. I'm giving you just an example. I did not measure it. Then I will minus 20% from it. How much I will get? Almost 16 mm. Then I will have to minus 2 mm safe margin. Then I will have almost 14 mm. Now I know I have to place 14 mm less implant. If your system you have 11 mm implant, you can place 11 mm implant on it. Same goes like over here. You will not go beyond this because the nerve will be passing through it. Okay. Okay, I am placing 2 implant over here. So to implant ratio, safe margin usually recommended is 1.5 mm. If you are placing 2 implant, after placement, there must be more space, more than 1.5 mm, not less than 1.5 mm. This is the ideally guideline. And if there is 2 implant, it should be almost more than 3 mm space, not less than 3 mm space. Okay. If there is a sinus, this sinus is very much low, but I am telling you, you have to give 2 mm safe margin from sinus. 2 mm safe margin from sinus. 1.5 mm same margin from tooth to implant, 3 mm from implant to implant. Okay, this is a guideline you need to assess in your X-rays. One more important thing. After placement of implant, there must be more than 1.5 mm in buccal side, 1.5 mm in lingual side. We have already assessed the vertical in examination in OPG. We have assessed the vertical pictures in OPG. But how will you assess the diameter? We have assessed the length. We have planned the length. We have abstract the radiographic error. We have abstract the same margin. We have abstract the anatomical variation. We have abstract everything from it. Then we have come up with 11 mm, 10 mm, 6 mm. How will you assess in diameter? CBCT is the ideal recommended. You can CBCT have no magnification error. You only mark it and place an implant. But safe margin is always abstract from everything. Whether it's CBCT, whether it's OPG, you will minus the safe margin if you are even placing. You are even assessing on the CBCT. You will minus the safe margin. Okay, but magnification is not minus from the CBCT. This is the same case which I have already told you. From tooth to implant, there should be 1.5 mm space margin, and from implant to implant, it should be 3 mm. One more thing, you should know what is the bone shape, bone angulation. If there is you have extract the tooth like this, first drilling should be like this. So implant can be used, plate implant like this. If you place the implant like this, there will be bone perforation, as I have shown you in the picture. Always place implant in straight position. But if there is an anatomical variation, if the adjacent tooth is displaced, you should know. If the tooth is displaced, then what you will have to plan. You can place the implant little bit tilted like this. Now we have abutment with 15-degree abutment, 25-degree abutment. Now abutment verification has also occurred. But mostly things are assessed in OPGs. If you are placing an implant straight, but the tooth is displaced, you have to little bit tilt the tooth. Why? Because if you drill it in the tooth will also be affected. This is the same guideline I already told you. You are placing an implant. Some say 1.1 mm should be from buccal to implant, but I usually recommend 1.5 mm. And from tooth to implant, 1 to 1.5 mm. We already discussed. Okay, now how you will assess it in clinically. First of all, reflect the flap. You have seen a vernier caliper. Place vernier caliper on both sides. If you can see almost 8 mm reading has occurred. You will extract 1.5 mm buccal side, 1.5 mm lingual side. Almost 3 mm is abstract from 8 mm, 8, 3, 4, 5, 6, 7, 8. 5 mm. You have 5 mm. You can place less than 5 mm. You can place 4 mm implant. You can place 4.5 mm implant. Mostly in anterior, we place 3.5, 3.75 till 4 mm implant. But in posterior, we don't place 3 mm, 3.5 mm or 3.8 mm because there are very much occlusal forces. They can fracture the implant. Mostly in posterior, we place more than 4 mm implant, diameter implant. Okay, this is an important point. We already discussed this. Okay, this is the one OPG you have seen the sinus. You have assessed it's 8 mm. You have abstract everything. You come with 6 mm plan. We have only 6 mm bone left. So whether you can do the bone sinus lift or you can place 5 mm diameter and 6 mm length implant over here, or you do the bone grafting by sinus lift technique or by crystal approach. This is not the today topic, but we will later discuss when we do the sinus lift, what is the protocol of it. We can also do this. We can also, if your system, if your clinic has OPG, you can place something on. If you are placing an implant, I have to place implant over here. I have to place implant over here. I have to place implant over here. You place a composite bond, or you have a, if you place a ball on it, metal ball, and you go for an OPG. Mostly I do the composite. I mark with composite. I make a tray. I place on patient and with composite, and I go for an OPG. If I now I know from this dot, mental foramen is almost close to it, but from on this dot, mental foramen is lower, so I cannot place implant on over here. But yeah, I can place implant over here. I can place implant over here. I can place implant over here. I can place implant over here with bone grafting, maybe, or I can go for all on four concept. We already we will plan sometime on what is on all on four. This is the patient with atrophic mandible, no bone in maxilla, some bone in mandible. We only use can plan over denture over here with 2 implant hybrid denture. This is a CBT which I was talking about. If you do your investigation on CBT, is the best thing you can assist. You can assist in all direction, buccal, lingual, palatal. This is a software, it can rotate according to your needs. You can rotate it on every side. You can see, you can mark the length, you can mark the width. This is the ideal. So you can know the angulation even. Okay, what kind of angulation is present over there. This is the same thing we have already discussed. This is the more, you can use this for diameter marking, vernier caliper, or this ridge mapping, ridge bone device. This is without flap, raising a flap. This you anesthetize the patient. You press the bone with these two sharp edges. It will hit the bone over here. You will know how much the diameter has over there. If you don't have CPCT, your patient is not willing to do the CPCT, this is the ideal thing. You can go for it like this, which I was talking about. You can see there is almost how much can see the thin People are also assessing from the file. I have never tried this technique, but yeah, you can also assess from the file. You place a stopper, you place on the buccal side, how much file is going in. You assess, oh, okay, there is 4 on the buccal side, of okay, 4 on the lingual side. You can also assess, but I have never tried this technique. We've already discussed from tooth to 1.5, from vital structure to for 2 from tooth to implant, from implant to implant, 3 from implant to buccal or lingual side 1.5. We've already discussed this thing. We've already discussed this picture. The thing was which I was telling you, if there is 5 the nerve will always come from the end, always come from the anterior with the huge loop for 5 loop. This is one of my case. Mostly guidelines do not recommend to place an implant in infected socket. You can clearly see in this picture, there is a infected socket and huge bony defect. Patient come to me with immediate loading. I extract the tooth. I place an implant almost 2 inside the bone, but I have cleaned all the infected tooth. I have clinically seen the socket is all clean. No infected debridement is there, and I have taken the risk. But after 6 months, you can see there is good bone formation. Articles and studies has code do not place on infected socket, but if you can try, you can also try on it. But you must most important thing, you have to clean the socket. Every infected tissue, whether it's in bone, whether it's in mucosa, whether it's in on outer surface, you have to clean, you have to trim, you have to cut it. If there is infected tissue on the soft tissue, I usually cut with the scissor, because if there is infected free site, there is huge chances that implant will be healed up. But in my case, there is a huge result, as you already seen in this picture. Okay, today is not our topic, hybrid, or I think what I have left. Okay, this was I am giving you a little bit. First of all, we give an incision, we raise the flap. We will start with the initial drill. After initial drill, there are different kind of drill: 2 mm drill, 3 mm drill, 4 mm drill, and 5 mm. Depend on which kind of implant you are placing 4 mm implant. You will not jump directly to the 4 mm. You will first go for 2 mm, then 3 mm, then 4 mm. Angulation is important. Drill should be in straight. You should know the root apex, root position. First of all, we go for this pilot drill, guided drill. We do the first we drill with this. We take an X-ray. After that, we drill 2 mm. Which kind of implant you are placing depend. If you are placing 4 mm, 4.5 mm, this is the drill. If you are placing 5 mm implant, this is the drill. Depend what is the diameter, what is the length. You have already seen this is the implant. This is the torque. You check the torque from the wrench. Ideally, guide and recommend do not exceed more than 40 mm. We are placing implant almost 80 mm. We are happy. Oh, we have achieved so much torque. We achieve 80 Newton torque. No, this is not good thing. There will be microfracture, there will be necrosis, and eventually implant will fail. Torque should be 30 to 40 mm. If you have achieved 35 mm torque and implant is in the bone, then this is the ideal recommendation. We assess the torque from here. This is almost 40 mm torque. Okay, I will like to close my session. Dr. Sara, you can proceed. We already exceed our time more than 20 minutes.
Thank you so much, Dr. Abbas, for this interesting webinar. So meanwhile, I will ask your permission to introduce our company to all the participants, and I request all the participants to kindly put their questions in the Q&A box if they have any. Can you please stop sharing your screen so I can share mine, please? Yes, thank you. So this is our organization, DentistChannel.Online, Healthy Smiles that leads to wealthy lives. Now I request all the participants to save this number and kindly send a message on WhatsApp with your name. This is how you will be added to our broadcast list, and then you will be updated about all our upcoming webinars and workshops. About our upcoming dental webinars, We have a webinar today with Dr. Sejal Shaha about cast partial denture. It will be tonight at 7 p.m. Indian Standard Time. About our upcoming dental courses, we have an intensive 4 days, 40 hours course about implantology with Dr. Anuj and Dr. Mohammed Sajid. It will happen between 7 and 10 October 2021 from 9 a.m. until 7 p.m. Indian Standard Time. Last but not least, I will invite you to join our second World Implant Expo. It will happen on 5th November 2021 via virtual platform with more than 30 speakers and live interactive sessions and scientific webinars. If you have any question about our webinars, our workshops, you can call or WhatsApp this number, and you can visit events.DentistChannel.Online to see more details about it. If you're not a Prime member yet, kindly join our family to benefit from a free certificate of participation after every event and benefit from discounts and special offers on our online dental courses, on-site dental courses, hands-on dental courses, and more events, workshops, and a lot more. To become a Prime member, kindly join this link. And the membership link, you can find it in the chat box. Kindly follow us on our social platforms, Facebook, Instagram, YouTube, and Twitter. So now, we can move to the question and answer session, but I think seems that all is fine. We don't have any question. You did a very well job, doctor. Well explained. Very clear session. Thank you so much, Dr. Abbas, for sharing your knowledge and experience with us. We are looking forward to planning another webinars and workshops with you.
Yeah, sure.
Thank you so much. Bye. Thank you. Bye.
Okay.